Pemphigus. The etiology of pemphigus includes it being an autoimmune disease. There is acantholysis and IgG autoantibodies are seen in the intercellular area of the epidermis. Coming to the autoimmune phenomena, the autoimmune phenomena can be idiopathic with no possible identifiable cause. There are IgG antibodies seen against the desmogleins, which are the structures that hold the epidermal cells together. The autoimmune phenomena can also be neoplasia induced. The most common neoplasms seen to induce pemphigus-like lesions are thymoma and lymphomas. There are certain drugs that can also trigger an autoimmune phenomena. These include penicillamine, rifampicin, and captopril. The following is the classification of pemphigus group of disorders: Pemphigus vulgaris, Pemphigus vegetans, Pemphigus foliaceus, and Pemphigus erythematosus. Coming to the epidemiology of pemphigus, the prevalence. It is the commonest cause of autoimmune blistering in India. The age group involved is the middle age between 20 to 45, but pemphigus may also occur in children. There is no gender predilection for occurrence of pemphigus. The clinics of each subtype. Pemphigus vulgaris. There are cutaneous and mucosal blisters, vesicles or bulla, which are flaccid, which means they rupture easily, and when they rupture, they leave behind painful erosions. These erosions may extend and increase in size. The sites of predilection of pemphigus vulgaris include the scalp, the face, the flexure areas such as the axilla and groin, and trunk. Coming next to pemphigus foliaceus. In this, the lesions are transient and the bullae are very superficial. Most of the time when the doctor sees the patient, the bulla, the vesicles have already ruptured, and most presentations are only with erosions. The mucosal lesions are very infrequent as opposed to frequent involvement in pemphigus vulgaris. The distribution of pemphigus foliaceus is seborrheic, that is the face, trunk and scalp. We can remember this by the seborrheic distribution of acne, which involves the face, scalp and trunk. Coming to the third subtype, which is the pemphigus vegetans. In pemphigus vegetans, the bulla is suprabasal. There are heaped up vegetating lesions that extend centrifugally. The most common site of involvement are the groins, the axilla, and even the angles of mouth. Mucosal lesions may be present as in pemphigus vulgaris. Now this is a picture of the groin area in a female with involvement of vegetating lesions involving the whole of groin. The next subtype is pemphigus erythematosus. It is a less severe variant of pemphigus foliaceus. The lesions will be in seborrheic distribution. The site of involvement, as in the picture, is the face, especially the malar regions and the dorsum of the nose. And lesions are triggered by sunlight and they are characterized by dry, hyperkeratotic and scaly lesions. Other variants of pemphigus include paraneoplastic pemphigus, which are triggered by an occult underlying neoplasm. Patients may present with erythema multiforme-like lesions, which are targetoid or target lesions, in which there's a central area of redness or blue discoloration surrounded by a perinuclear halo and then again a rim. So it looks like a target, as in a shooting target. Patients may also present with mucosal lesions which are extremely painful. As we discussed before, the drug-induced pemphigus can be triggered by a drug known as penicillamine, rifampicin, and captopril. They present with a pemphigus foliaceus or pemphigus vulgaris-like picture. There's something known as Fogo selvagum or Brazilian pemphigus, which is usually seen to be triggered by infectious occult agent in that particular region. The following are the pictures showing paraneoplastic pemphigus, drug-induced pemphigus, and Fogo selvagum or the Brazilian pemphigus. Investigations in a patient with pemphigus. The most important investigation is making a Zank smear. Now the Zank smear is made by de-roofing the bulla, collecting the little fluid on the base of the bulla and putting it on a glass slide and staining with Giemsa. What is seen are characteristic acantholytic cells, as we'll see in the next slide. The histopathology, if a biopsy is taken, shows intraepidermal bulla with acantholytic cells. The immunopathology or the direct immunofluorescence shows intercellular fishnet pattern with IgG deposition in the epidermis. Now these are the acantholytic cells which are characteristic of pemphigus. The acantholytic cells are small round lymphocytes which have a central condensed nucleus. There is a perinuclear halo and the entire cytoplasm is condensed in the periphery, as we can see in this cell as well. This is the fishnet pattern on the direct immunofluorescence that depicts IgG deposition in the intercellular spaces, which are actually the bonding places of the desmogleins. The most important differential diagnosis of a pemphigus vulgaris is a bullous pemphigoid. Now, the pemphigus vulgaris happens in a young age individual, whereas bullous pemphigoid happens in old age. The bulla seen in pemphigus vulgaris are flaccid. They break easily. They are superficial. Whereas the bulla in bullous pemphigoid are tense. They are deep. They don't break easily. On histopathology, there is intraepidermal. That means within the epidermis, bulla and acantholytic cells. Whereas in bullous pemphigoid, the lesion pathology is in the dermo-epidermal junction. So where the epidermis meets the dermis. In DIF or the direct immunofluorescence, IgG deposition is seen in the intercellular space in a fishnet pattern, whereas in a direct immunofluorescence in bullous pemphigoid, we see a linear band of IgG and C3 at the junction of the dermis and the epidermis. This is a lesion of the pemphigus vulgaris on the left, shows a flaccid bulla, whereas bullous pemphigoid shows very tense bullae. Now coming to the treatment of pemphigus. We need to treat the patients extremely aggressively since it's a life-threatening disease. Supportive care is very vital in the treatment of pemphigus patients, which include care of the eyes, care of the mucosal areas. So we need to involve other specialties such as ophthalmology, otorhinolaryngology, and even surgical help may be required in patients with pemphigus. The medications that we give in patients of pemphigus include steroids, which may be given along with other immunosuppressives such as azathioprine, methotrexate, and cyclophosphamide.